Okay, so my remit today was to talk about non-surgical treatment options for nystagmus. So, as Joe's already said, our centre in Leicester, we do run clinical trials for nystagmus. So what I've decided to try to do today is give you an overview of the literature. So any treatment that is non-surgical that has been reported to be useful for nystagmus, or not useful as the case may be, for nystagmus. Okay, so first of all, nystagmus then, to and fro oscillation of the eyes. It can cause reduced vision, oscillopsia in some cases, and what we found in Leicester was that visual functioning scores are actually worse in nystagmus than in other eye diseases such as age-related macular degeneration. So first of all, when we're talking about treatments, treatments have now become directed to different types of nystagmus. So just before I start going into the different treatments, I just wanted to go over some of the nomenclature. So infantile nystagmus, this refers to nystagmus that develops within the first few months of life. It can be idiopathic, so it can have no known cause, or it can be associated with other eye diseases. So the most common that we tend to hear about are albinism, retinal diseases, other conditions that cause low vision in early life. And then there's acquired nystagmus, and this develops in later life. And most commonly we see it due to neurological diseases such as multiple sclerosis, stroke, ataxia, tumour, and sometimes drug intoxication as well. And acquired nystagmus usually does cause oscillopsia. So we were interested in Leicester at looking at nystagmus from the perspective of the people that have the condition. So we have interviewed adults with nystagmus, and we wanted to know how quality of life is affected in people that have nystagmus, and what are the areas that we should be addressing. So what should we be measuring when we're looking at treatments? So we interviewed 21 participants, and of those 21 participants, we analysed the data as we went along. And what we did, the way that we analysed the data was that when we reached theoretical saturation, which is the point at which no new themes emerged from the interview transcripts, that's when we stopped analysing the data. And we found 6 main themes from our interviews. So the first one was standing out. So the perception, how the nystagmus looks and what other people think about the nystagmus. Then there was the restriction of movement. So this was the restriction of physical movement, so getting from place to place, and also the restriction of social movement, so access to leisure activities and things like that. And then there were feelings about the inner self. So within this theme we had thoughts around self-confidence and self-esteem, thoughts about the future and how the future looks when you've from the perspective of the person that has nystagmus, trying new things. Also within this theme was, and this is something that I will talk about as well, was the medical community and the way that they deal with nystagmus. The effect on relationships, so both personal and professional, and then also physical function. And within this theme, this is where we included visual acuity. So you can see from the themes that we found, we actually found nystagmus to be much more than just about improving visual acuity. So just to give you an example of some of the things that were said by our people, not for all of the themes, I've just chosen some themes. So first of all, standing out, and one of the sub-themes within standing out was other people noticing. So main effects are just people's perception of you and your own perception of people's perception of you, really. I'm often in situations where nobody would know that I'm visually impaired at all were it not for my nystagmus. But because it's there, emotionally, psychologically, it makes a massive difference. And then another participant said, people think, what's that with your eyes? Why are they moving? I don't tend to look at people in the eye, or if I do, it's sort of fleeting, because I still feel embarrassed about them seeing my eyes moving and thinking, what's she doing? So from this theme, we realised that actually when we're looking at treatments, it's not just about the visual acuity. So it's just as important to try and reduce the eye movement. And then the future. So this there was a sub-theme about being abandoned, and this was particularly with regard to the medical community, medical professionals. And each time something doesn't work for me, I'm paranoid about being chucked out into the wilderness again. And that's it, and that didn't work, sorry, goodbye. And then go away and forget about it yourself. And that's basically what I've been told all my life by the professionals. It's always been a case of, well, what do you expect us to do? It's nystagmus. There's nothing we can do about it. So perhaps they could be a little bit more sympathetic and at least pretend to be doing something. Okay, and then within the theme, the restriction of movement, there was this sub-theme of driving, and not about not being able to drive, but the effect that not being able to drive has on other areas of life. So, for me, it's not being able to drive that's the main issue. If I could just get my eyesight just so I could drive, I would be happy. And then other things that worry me about becoming a parent, not being able to drive, I'd have to structure my life quite differently, choose where I live, but essentially just things I need to be close to, rely on public transport, which I really hate, and rely on other people a little bit too much as well. And then most jobs that I want to apply for, they ask for a driving licence, so that's kind of hit me hard. And then feelings about the inner self, so one of the sub-themes there was about confidence. I feel if I didn't have it, I'd probably have a greater, more confidence, and I'd be able to live in a better way. My personality would be different, you know. I'd be a lot more confident, more outgoing, and have a different career. I think things would change significantly if I didn't have this eye condition, and it's hindered my confidence, which will affect my public speaking, which I need in my future career choice. And then we found this overlying theme as well that every participant mentioned, and this is that nystagmus affects every aspect of everyday life. So it creeps into everything really, everyday life. It's all rolled up into one really, it's just there all the while sort of thing. It affects your daily life and it will do for the rest of your life. Every aspect of growing up and becoming an adult has been affected by it. And I just want to get on with stuff normally and it not bother me and it not get in the way of doing what I do every day. So that's just a summary of some of the negative findings. But we also did find some, I don't want you all to go away depressed. So we also did, I wanted to just to stress that we did find some positivity and coping mechanisms that people use as well. So don't let it define you really, it's not the be all and end all. Contact with parents whose children have nystagmus, it's nice to be able to tell them that it doesn't need to let you not achieve things. It's looked at as something quite different, but actually it's quite unique and cheeky. And you battle on and you say, well, I can do it better than anyone else anyway, and you get on with it. And it's not the end of the world. It might stop you driving, but everything else you can get through. Okay. So we concluded with our interviews that nystagmus impacts upon much more than just the functional issues such as visual acuity, and it also affects social and psychological domains of life as well. So it's not just visual acuity that's important, and the appearance of nystagmus is also an issue. So reducing eye movement is just as important as improving the vision. Okay, so just before I talk about the studies that are available for nystagmus, I just wanted to make you aware of what we see as the gold standard. So the gold standard for a study is a randomised controlled trial whereby treatment is masked to both the patient and the investigator. So by a controlled trial, we mean that the whatever is being tested, be it a drug, be it a contact lens, that we compare that to a placebo treatment. So by placebo, we mean a sham treatment, so no actual medication or so with a contact lens, we compare to glasses. Unfortunately, many studies that are reported for nystagmus are not randomised controlled trials. And reason being is that randomised controlled trials are very costly, they are time consuming, it takes a high level of expertise, and you need the correct number of patients that are actually willing to commit to the time in the study as well. So when we look at non-surgical treatment options, when I was looking at the literature, they fall into kind of three categories. So you've got your optical treatments, you've got pharmacological treatments, and then there's other treatments. So this is the way that I'm going to work through it. So just in the room, I just want to put the question out there. So what do we feel is the most important intervention for infantile nystagmus? What would you guys say is the most important intervention for infantile nystagmus? So glasses. So the correction of refractive error. So we see it with nystagmus that most of our patients have a refractive error, and we see quite high levels of astigmatism as well. So, and it's just as important whether you've got nystagmus, it's as important if you have nystagmus as if you didn't have nystagmus, that we correct this refractive error. And then quite commonly, when I'm chatting to patients, the question that comes up is, I have infantile nystagmus, can I wear contact lenses? So there are studies that have suggested that contact lenses may be beneficial in nystagmus. And it suggested that they may be beneficial because contact lenses actually move with the eye. And there's also been some suggestion in the past that contact lenses might, because they're actually touching the eyelid and they're moving and touching the eyelid, that they give some feedback to the brain via the inner eyelid. So then the brain then has some control over the eye movement. So, I have a video here. So this is a patient with a head posture, one of our patients with a head posture. And so you can see here, what we're getting him to do is we're getting him to read down the eye chart. And as he gets further down the eye chart, his head posture becomes more pronounced. And then he's actually having to look over his glasses because the frames are getting in the way of him. So he's fighting between using his optical correction and using his head posture. So in a situation like this would be an ideal situation to use contact lenses because they actually move with the eye. Okay, so studies of contact lenses. So there have been a few studies using contact lenses. So there's been studies that have used hard lenses, and there's been studies that have used soft contact lenses. So previous studies that have used hard contact lenses, and 5 studies that have previously used soft contact lenses. Now what we can see is that in terms of visual acuity, there's been variable amounts of improvement that have been shown in the studies. And in terms of nystagmus outcomes, so in terms of the actual eye movement, again, some studies have shown a reduction in the nystagmus, some studies have shown a variable outcome. So up until recently, visual acuity and eye movement results vary, and these were not randomised controlled trials either. So what we did in Leicester was we went ahead and we performed a randomised controlled crossover trial of soft contact lenses and hard contact lenses. And we included 12 patients with albinism and 12 patients with idiopathic infantile nystagmus. So by the term idiopathic, we mean it's there for no known cause. And the way that our study worked was the patient came at visit 1, and at this point that we examined the patients, and then they had they saw our optometrist and they had their glasses checked. And then they wore glasses for 2 to 3 weeks, and then they came back for visit 2. And at this point, they were prescribed either soft contact lenses or hard contact lenses. And then they wore either of the lenses for 2 to 3 weeks, and we examined the patients again. And at this point, they swapped over. So if they'd had hard lenses the first time, we then prescribed soft lenses, and they wore them for 2 to 3 weeks. And then they came back for visit 4, and we examined the patients again, and then they wore glasses for 2 to 3 weeks. So for this study, our findings were different to some of the other studies in that we found no difference in the eye movement. So the nystagmus intensity and the NAFX, so the foveation characteristics of the nystagmus, were no different with contact lens wear as with glasses wear. Now, interestingly, in terms of visual functioning, we found that logMAR VA and reading scores, so visual acuity and reading, were significantly worse with soft contact lenses compared to hard lenses and glasses wear. Now, when I talk about significance here, I'm talking about statistical significance, not necessarily clinical significance. So this is in terms of statistics. So what we did is we went on to explore why the vision was slightly less with the soft contact lens wear than it was the hard lens wear and the glasses wear. So what we did is we popped a lens in the eye. So this is a soft toric lens. So a soft toric lens needs to be in a certain position to correct the astigmatism. So what you can see here, we marked up the lens at the 6 o'clock position, and we found that the lenses were being knocked out of position by the nystagmus. So that was our conclusion as to why there was a reduced visual acuity with soft lenses as compared to hard lenses and glasses wear. And that's not to say that soft lenses don't work at all, but what we would say is that in cases of high astigmatism, we may consider prescribing hard lenses first. Okay, so we just need to be aware that maybe the soft toric lenses might not be the best prescription in the first instance for people with high astigmatism. Then also in terms of optical treatments, we can use prisms. So we can use prisms in 2 different ways. So with nystagmus, there is in some cases there is a reduction in nystagmus on convergence. So when the eyes come together, if you're viewing something at near, then the nystagmus may reduce. So we can use prisms to create an artificial divergence, which then forces the eyes to converge in the hope that we might reduce the amount of nystagmus. We can also use prisms to displace the point of central fixation towards the null point. So we can move the eyes towards the null position as well. Now, that's not, we don't tend to use that as a long-term treatment in Leicester, and I don't know, I think, because actually prisms are quite heavy. But we might use it to see whether surgery would be applicable in the case of a head posture. So this was one of our patients, and this was before. This is a video here before he had prisms. So, and then we incorporated some prisms into his glasses, which was creating an artificial divergence and therefore forcing his eyes to converge. And there was a slight dampening there of the nystagmus after the prisms were incorporated into his glasses. So in terms of pharmacological treatment of nystagmus, so drug treatment, there's been lots of different drugs that have been tried, but the majority of these publications are case reports, so they're not randomised controlled trials. In recent years, what we have found, though, is that different types of medications have been targeted towards different types of nystagmus. So in cases of acquired pendular nystagmus, the drugs of choice seem to be gabapentin and memantine. For periodic alternating nystagmus, baclofen. For downbeat nystagmus and upbeat nystagmus, we're looking at drugs called aminopyridine, so 3,4-diaminopyridine and 4-aminopyridine. And then for infantile nystagmus, gabapentin and memantine. So I'm just going to run through some of these different types of nystagmus and show you some videos. I thought that and then where we've actually used treatments in Leicester, just to show you before and after treatment. So first of all, downbeat nystagmus is present in mid position, but it worsens on down gaze and side gaze. And we most commonly see downbeat nystagmus in cerebellar degeneration, Chiari malformation, infarction, so stroke, and drug intoxication. Now, I don't know if this video is going to work, because this is the one that we were struggling with. So this is an example of downbeat nystagmus. It's not going to work, is it? So basically, what this video showed was that the eyes were relatively quiet in primary position. As the patient looks down, there's an increase in the nystagmus, and as the patient looks to the side as well, there's an increase in the nystagmus. So this is a patient with Arnold-Chiari malformation and downbeat nystagmus. Okay, so as I said, the most recent reports for the treatment of downbeat nystagmus are potassium channel blockers, so 3,4-diaminopyridine and 4-aminopyridine. Now, unfortunately, in the UK, we can't get hold of these drugs. It's very, very difficult for us to get hold of these drugs. There's a drug called Vampira that I believe, Vampridine, and I believe that these drugs are available in the US. When I'm talking to Rich, and I think that he's able to prescribe these drugs. Now, there are RCTs, there are randomised controlled trials, so there are randomised controlled trials that also compare 3,4-diaminopyridine and 4-aminopyridine, and these comparative trials have concluded that 4-aminopyridine has led to a bigger decrease in nystagmus than 3,4-diaminopyridine. So then there's upbeat nystagmus, and this occurs infrequently. We don't see this as often as the other forms of nystagmus. And this usually increases on up gaze, but not on side gaze. And primary position upbeat nystagmus we most commonly see in conditions such as stroke, Wernicke encephalopathy, and multiple sclerosis. So just an example here of upbeat nystagmus. Is one working? Yep. So it's for this particular patient, it's quite a fine nystagmus, and you can see here in primary position the nystagmus is beating up, so the fast phase is up. And again, there are few reports for upbeat nystagmus and pharmacological treatment. Again, it's potassium channel blockers that are the drug of choice. Again, in the UK, we can't get hold of these, so I don't have any pre and post treatment videos to show you. And 4-aminopyridine has been shown to dampen nystagmus in the primary position in upbeat nystagmus, and also relieve oscillopsia as well.
Why are the drugs not available in the UK?
why the drug's not available in the UK. They're not licensed, are they, in the UK? So we did try and put in an application to be able to use the drugs, and they're quite expensive, and our unit was just, we were refused. Yeah.
They felt it was too costly.
They felt it was too costly, so we're just not allowed to prescribe. So we've got this big cohort of downbeaten, upbeaten patients, and we just can't, there's not really a lot we can do for them. And actually that's where I would like to move on to next, but just so costly. Yeah. Okay, so periodic alternating nystagmus, sometimes known as PAN. This is probably the best understood form of acquired nystagmus, but it does also occur in infantile nystagmus. And this is a primary position nystagmus, so it's there in the central position, and it periodically alters direction after approximately 2 minutes. So I've got a little video here to show you. So this patient here, so she's right beating. And then after it's usually between 90 seconds and 2 minutes, the eye movement slows. So after 2 minutes observation, the eye movement slows, and then she'll start to beat towards the left. So she switches to left beating. Okay, so there's lots of treatments that have been shown not to be effective in periodic alternating nystagmus, but there are case reports that suggest a PAN responds very well to baclofen. And having spoken to Rich over the last couple of days and at the workshop, I know that Rich does routinely prescribe baclofen for these types of patients. So acquired pendular nystagmus, or APN, this is a sinusoidal movement, and it can occur in horizontally, vertically, or it can be a combination of both. So we can see it in the horizontal plane, we can see it in the vertical plane, or sometimes we see the eyes moving in a rotary fashion. And this occurs in many conditions, but the two most common that we see are conditions such as multiple sclerosis and stroke. So here we can see, so this is a patient with acquired pendular nystagmus and MS. And so you can see here, so in prime position, this patient, the majority of the movement is a vertical movement, but because there is a horizontal movement as well, you can see the eyes that do appear to be doing this, and the video is not working particularly well again. Okay. And then, so this is a patient with acquired pendular nystagmus and occipitatal tremor. So this patient had a stroke. And so as well as this movement with the eyes, what we also see is the palate, a tremor on the palate as well. So when we looked into his mouth, you can see the palate's making a similar sort of movement. And the patient actually reported that he felt that this was in, that it was in conjunction with his heartbeat, the movement in his palate. So with acquired pendular nystagmus and pharmacological treatment, there are RCTs, and gabapentin and memantine are the drugs of choice. Both gabapentin and memantine have been shown to reduce nystagmus, reduce oscillopsia, and also improve vision in these patients. So this lady here, so she has a conjugate nystagmus, so there's more nystagmus in the left eye than there is in the right eye. So you see her eyes, she's got quite a rotary nystagmus. And this is before we gave her any treatment. So, and this particular lady as well, she suffered from oscillopsia. Her biggest complaint was the oscillopsia and the perception of the world moving around. So we started her off on gabapentin treatment. Okay, so if we look at the movement, it is about, when we looked at the eye movement recordings, we didn't feel there was an awful lot of difference with the gabapentin, although she subjectively did report that she felt that there was an improvement. So what we did was we also added gabapentin, memantine to the gabapentin, and the combination of the medication, you can see if we look at the left eye here, has dramatically reduced the nystagmus. So she was extremely happy. So she's been on gabapentin and memantine now for about 7 or 8 years. So moving on from acquired nystagmus then, and infantile nystagmus. So gabapentin and memantine have been compared, so gabapentin and memantine, moving on from the studies in acquired pendular nystagmus, gabapentin and memantine have been compared to placebo in an RCT for infantile nystagmus. So, and we performed this in Leicester. So we had 48 patients with infantile nystagmus. We had, within the 48 patients, there were patients that had idiopathic nystagmus, so it was there for no known cause. And we also had nystagmus that was associated with other eye conditions such as albinism, retinal diseases, congenital cataracts. So for this particular study, each patient received either gabapentin or memantine or placebo, and they received 8 weeks of treatment. And in this first study that we performed, we actually found that gabapentin and memantine did improve vision and eye movement in the idiopathic group, and gabapentin and memantine reduced eye movement in the group associated with other eye conditions. So the group that had other eye problems and not just the nystagmus, we didn't see an improvement in vision in that group. So what I've got some videos from this trial that we performed. So this is one of our patients before gabapentin. It's not working. Let's have a look. Okay, so she's got a horizontal jerk nystagmus, so ocular albinism and nystagmus, this patient here. And then the next video, we can show you, this is the same patient again after treatment. So she's receiving 2,400 milligrams of gabapentin. She's been on treatment for 8 weeks, and she had a significant reduction in the amount, in the intensity of the nystagmus.
What about again in combination?
So
Using memantine and gabapentin together.
in infantile nystagmus, so we have a few patients that we do that for. We have got a few patients, but these are trials. So for these particular trials, we need ethics. So we had ethics to just prescribe the drug singly in these trials. But clinically, we have got in Leicester, we've got a couple of patients that we have combined the patients that we generally tend to start them off on gabapentin, and if there's no improvement on gabapentin, then we in the past we've tended to switch and then prescribe memantine, and then if there's no improvement, then we'll combine the medications as well. Okay, and for this same trial, this is one of our patients. This patient has idiopathic infantile nystagmus, and this is the patient before memantine treatment. Again, predominantly horizontal nystagmus, and then this is the same patient after 40 milligrams of memantine treatment. So you can see there was in this particular patient there was a vast reduction in the amount of her nystagmus.
What did they report? What was their verbal report?
Sorry.
What was their verbal report?
So this lady was extremely happy on 40 milligrams of memantine, and this trial we published in 2007, and she's still on memantine now. So she was extremely happy. But I will be moving on. We've performed a more recent trial, and so I'll show you the results of those as well.
Was the vision increasing afterwards? Did she actually had a better vision?
She did have a better vision afterwards as well. Yeah.
How long does such a medication
Last?
last?
Yeah. So you would have to take it. You would need to continue taking it.
And in which frequencies?
Every day. Every day, yeah. And then just to show you, just a comparison, this was one of our patients before he was on placebo, so this was before placebo. Again, patient with idiopathic infantile nystagmus. And this is the same patient again after treatment. So you can see there's no real difference in the eye movement. So with this particular trial, we didn't have an awful lot of money, so we just wanted to see whether the drugs worked. So that's why. So we just got the drugs into the participants' system, and just to see whether we felt that there was any improvement in visual acuity and eye movement. But we felt that there was a more appropriate study design than a parallel arm study. So a parallel arm study is where each patient receives one of the treatments. And we didn't know what the optimum dose and the duration of treatment was. And we also didn't know whether there were specific subtypes of infantile nystagmus that responded either to memantine or gabapentin. So this is the most recent trial that we've performed. So this was our study design. So this time we performed a crossover trial. So each patient received gabapentin, memantine and placebo in a randomised order. So we had 66 participants who each received a total of 16 examinations over a period of 483 days. And there were 3 possible sequences of treatment. So they either received memantine first, then a washout period, then placebo, then gabapentin, then placebo, then a washout period, then gabapentin, then placebo, gabapentin, memantine, or gabapentin, memantine, and placebo. And the way that it worked was we had 3 phases for each drug. And so for visit 1, they would come and we would examine the participants, and then we would up-titrate the medication to either 20 milligrams of memantine or 1,200 milligrams of gabapentin, or an equal number of capsules of placebo. Then we would see them again after 15 days. We would examine the patient again, and then we would maintain that dose for 6 weeks. And then the patients would come back to us again, we would examine the patients again, and then we would increase the medication to the maximum dose of either 40 milligrams of memantine, 2,000 milligrams of gabapentin, or 8 capsules of placebo. And that was over a 20-day period. And then we would examine the patients again, and then we would maintain that dose for 6 weeks, and then we would see the patients again, and then they would have a washout period, and then the process would start all over again with a different medication depending upon what they'd been randomised to. So this study as well, just to bear in mind, these studies are masked, so I didn't know what the patients were taking. All the drugs were re-encapsulated, and the patients didn't know what they were taking either. Now, for this study, we found that memantine and gabapentin did not significantly improve visual acuity in either the infantile nystagmus group, idiopathic infantile nystagmus group, or the nystagmus group with associated sensory problems as compared to placebo. But what we did find was that gabapentin reduced the nystagmus intensity as compared to both placebo and memantine. When we looked at the time course of the drugs, it suggested that gabapentin was probably at its most effective after the initial dose, and then directly after a dose increase. And the other thing that we found that was very interesting with this study is that pendular waveforms. So when we look at the nystagmus and we record the eye movement, we can look at the waveform in detail. And we found that pendular waveforms were more prominent in participants reaching success. And this fits in with the acquired pendular nystagmus studies that have been previously reported. And we had a very low dropout rate, so just 6.6% of patients for memantine and gabapentin and a 5.3% for placebo. So, why did we have different results to the first randomised controlled trial? Well, it's probably down to the study design. So this time we had a longer duration of study, and because it was a crossover trial, there were even baseline characteristics in each group because it was the same patients. And we had an even sample size in each treatment group. So we think about the first trial where we saw an improvement with memantine. In the idiopathic memantine group, we only have 5 participants, and we had one lady, which was the lady that I showed with quite the dramatic decrease in eye movement, and she improved quite drastically, which may have skewed the whole group. But I have still got further analysis to look at in more detail at the responders and the non-responders for the treatments, and I think this may lead us to know who will be more suitable for treatment with gabapentin. Then something else that we don't do in Leicester, but it's there, it is in the literature, case reports, botulinum toxin injections, and we see these mostly in acquired nystagmus, and this is an injection into the muscle, and this has been shown to reduce nystagmus and improve vision, but the effects are short term, and sometimes the side effects outweigh the success of this treatment because ptosis and so droopy eyelids and double vision can occur.
So this is what we would call Botox?
Botox, yeah. Probably the newest research that's out there at the moment is with a drug called Brinzolamide. So these are more commonly known as Azopt eye drops, and they're used for glaucoma. Now this is a study that Richard's been working on, Richard Hurtle, and recently he's published a crossover double mask control trial. So there were 5 subjects with infantile nystagmus, and so they received the active eye drop and then a sham eye drop in a randomised order with a washout in the middle. And he reported that 4 subjects, their vision significantly improved by 1 or more logmar lines on the chart, and there was also an improvement in eye movement characteristics. So I think this might have some potential actually. We don't know the mechanisms of how the eye drops work, and I was hoping that Rich would be here, but he's had to fly out, but just so he could go through this in a bit more detail. But Azopt eye drops are readily available for use in glaucoma. So this, I think there is more work that needs doing in this area, but it's potential.
Is this something that you would suggest, because everyone here, especially the parents, are just looking at, what can I do?
Yeah.
Is this, are any of these things that you would, should they be asking their doctor? Is it just to get this knowledge of it? Should they wait for awareness to be raised in the general treating community? What's your take on that?
So in terms of pharmacological treatments, most of these treatments have only been used in adults. Okay, so what we need to do is we need to try and take some of these children, some of these treatments down to the level of children. Now, probably gabapentin would be the first place to go with this, because it is licensed for use in children in epilepsy. So, so in terms of pharmacological treatment, I think we're struggling at the moment in terms of children. But in terms of the optical corrections, and we've got what I was going to do at the end was, because we've got quite a lot of expertise in the room, so I was going to open it up for questions to everybody, to all the experts that are in the room, because we've got Lee, he works for the optometry department in Cardiff, and he might be able to answer the questions in a bit more detail about the contact lenses. So it might be easy if we wait until the end. Yeah. Okay, and then there are a number of early studies that suggest that feedback may improve nystagmus characteristics. So auditory feedback, so this is using sound to give feedback of eye movements and to train the patient to control the nystagmus. And there's a suggestion that this auditory feedback and being able to hear what your eye movements are doing improves nystagmus during the session that they was occurring in, but there is a question mark whether this is maintained afterwards. And then we've also got acupuncture. So this is a study that Larry was actually involved in, so I can direct any questions to Larry with regards to this. So they, in this particular study, they inserted the needles into the neck muscles, and they found that the eye movement characteristics improved in 4 out of the 6 participants with infantile nystagmus. And they also concluded that these findings supported previous studies that used electrical or vibratory stimulation on the same area of the neck. So again, but as I say, this is something that Larry was involved in, so I'm hoping he will give us a bit more detail with regards to this. So in summary, there's a number of potential non-surgical treatments for nystagmus, but there's definitely a need for more randomised controlled trials to improve the quality of the evidence. So when we look at treatments and clinicians prescribing treatments, what they're looking at the evidence base for these treatments. And because we've got a limited amount of RCT, randomised controlled trials, it's difficult for clinicians to implement treatments because they just haven't got the evidence there to be able to implement treatments. So just a final thought. So this was one of my patients that I interviewed, and he said, take nystagmus seriously. It may only be a few dozen thousand of us who've got it and so on, but we are severely affected by it. And return on investment could be remarkable because there are so many of us who could do so much more. Okay. So just want to acknowledge my my funders, and if there's any questions, as I say, there's lots of experts in the room, so I think we can utilise everybody that's in the room if you've got any questions. Okay.
So if I go to my doctor and request one of the 3 drugs that we talked about, is that even within the scope of them prescribing them to me? Or
Okay,
so be in a study?
No. So I think gabapentin most definitely. The problem is I know what's available in the UK, but I'm not 100% sure as with regards to the US. But I assume if it's available in the UK, then it will be available in the US. So I would say gabapentin would be the first port of call in terms of treatment. Looking at the findings for our recent study, and it should be available. Yeah.
the medications are available, they would be used what's termed off-label.
Off-label, yeah. Yeah.
That's the term.
Yeah.
Yeah, I know in Australia people are using brinzolamide just on a case-by-case basis.
Okay, yeah. So that's the Azopt eye drops.
Yes.
Yeah.
Ophthalmologists, yeah, that's second nature.
Yeah.
I would say though, be careful about pushing too hard for any of these things. But there's a reason why these things are off-label, and there's a reason why people are prescribing them all the time. A lot of these things have significant side effect profiles. What you're trying to improve, it might be this. What you might actually have as a side effect might be that. There's a constant balance to make, so I'd be very careful about being too pushy with your dogs. I'm saying that because of the dogs.
And in terms of evidence that comes back to us at the Nystagmus network, I said there were three responses. People for whom drugs don't do anything, people for whom drugs do help, but as Joe says, the side effects aren't worth the effort. By side effects, they're often, trivial things in a way. Diarrhea, headaches, but if you're going to have those all your life. And then there's a third group for whom they do work, and they say, brilliant, improve my vision, I can drive, whatever. How big each of those groups are, I don't know, but there's definitely three separate groups there.
But as Rebecca said, we're not talking about nystagmus. I know it says commonly, nystagmus is not the thing, it's what type of nystagmus.
What, yeah.
There's really evidence, as Rebecca said, some types.
Yeah.
So a particular type of nystagmus.
So this is going back again to what we were saying this morning, and what the conclusion that we've come to from the workshop is we need to be looking more at diagnosis. We need to be finding out what's causing the nystagmus, and then we can then direct treatments towards the specific types of nystagmus.
It's interesting when you talk about the types of nystagmus, and I wonder if many people in the room even have a clue. Like, I don't know what kind of nystagmus I have. Had tests and stuff. I don't think there's a great amount of awareness amongst people with as to what kind they do have. And would you recommend people do find out what
Yeah.
kind they have?
Absolutely. I mean, I think we're all of the agreement that knowledge is power at the end of the day.
Well, I mean, we talked about this earlier.
Yeah.
It's a bizarre situation in a way. You wouldn't have a headache conference including people with migraine, cluster headache, brain tumours, and all sit around and talk about headache in the same way,
Right.
People find out what they've got. So if you're going to push your doctor for anything, and I would recommend this, push them for why there's nystagmus, what the features are, what type of nystagmus you have, because that's the information you need to know if you then want to start something.
Well, I think they'll just say infantile nystagmus. How could you equip us to have that conversation to the doctor to say, because they will just say you have, acquired or congenital or infantile. They're not going to go much further. Am I right?
Isn't that where eye movement recordings come
Well,
in?
eye movement recordings will tell you about the waveform, but I think somebody in the morning session in here said that, I think with their child, that the doctor said, well, you have nystagmus, there's nothing we can do, didn't do a retinal exam, no sensory evaluation, and there's evidence that even if we don't know why, say nystagmus, infantile nystagmus associated with albinism, for instance, may respond differently to treatment than, because you found that in your...
So in the workshop, interestingly, the other thing that we found with this recent trial was that in terms of the dampening of the eye movement with gabapentin, the impression that we got was that it was more with those people that had other sensory problems than those with idiopathic nystagmus. But as I say, I've got so much data, and I do need to look at it in more detail. But I think as much as anything, what we wanted to try and get across today was there are other options. It's not just straight down the surgical route. I think as much as anything, I think you start off with the least invasive, and then move forward. Once you've found out what you've got.
That's really the first thing to
Yeah.
push for. Is just because your eyes are wiggling doesn't mean you don't need to examine the eyes.
Yeah.
So can I just add, sorry, what you said, Jim? I think maybe a way of empowering to do that is to have a minimum set of things that every nystagmus patient should have. We were talking about this earlier.
Yeah.
It doesn't need to be exhaustive mega list, but it could be a list of maybe 3 things. But if your eye surgeon says that I don't have facilities for that, you can say, can I go somewhere that does?
Yeah.
That would be a basic.
And I think, I'm going to say what everybody is around while talking about it. It's true, because when I went to see him, he was able to tell me why I have nystagmus, the underlying reason, and now he's got even more to lose.
Absolutely, but there's lots of doctors seeing the
That-
tablets all the time.
yeah.
They don't come on the radar.
That's true, no, that's true, but I think they have to have the tools.
I think as well, I should show all our patients that we see for these trials, they're all worked up previously, and they all have a diagnosis, and we don't, when we include patients into these trials, we know what they've got and we're directing the treatments.
That's an advantage of the UK setup.
That's an advantage of the UK setup, but we do feel, I think this was something again, there should be protocols in place, so there should be sort of hubs whereby like a diagnostic procedure is available for everybody.
I know that during the last days that there's a complex system since I was so the eye, the vestibular system, the mind, the nerves, and on which does the chemicals affect?
So for the drug treatments, they act on different receptors in the brain, and each drug has a very different action as well.
The receptors.
Yeah.
Where?
And we don't know where. We don't know why they work. Is a thing.
Even know why people have nystagmus.
Yes.
Yeah.
This is a thing.
Yeah.
This is a problem. Yeah.
Right at the start.
We are.
I think one of the issues here is that a lot of we talk about receptors, they're the things that respond to the chemical of the cells, if you like, but a lot of these receptors are found throughout the brain.
Yeah.
They're found in the visual system, they're found in the motor system, so that's why we really don't know what's going on.
Well, this is really interesting because if you work on the written directly with the snake and so the scales and movement of the eye, real
Some of the eye drops, we had one of the other speakers who couldn't be here, Linda McLean, studies eye muscle, and found there's differences in the muscle fibers of the eye muscles in people with nystagmus, and there's even differences between people with albinism and not. And so presumably the eye drops may be acting at that level, but how, we don't know. So we don't really know why the muscles are different. Is it a cause or is it an effect? There's a huge range of question marks out there.
challenge in research.
Yes.
Mm-hmm. Yes.
Do you know if baclofen and gabapentin have both been prescribed and neither have worked, why there is a reason that memantine hasn't been prescribed?
Has it?
Is there anything that would stop it and that would work? Would that say memantine would do any better or won't work either?
So I think in terms of infantile nystagmus,
It would be for acquired.
so for acquired nystagmus, so memantine. So the question again. Sorry.
Baclofen and gabapentin have both been prescribed and neither have worked. Would there be a reason why memantine wasn't then the next?
In acquired nystagmus. Well, it depends on the type of nystagmus again. So for acquired pendular nystagmus,
I think it would be like
a vertical. Well, there's not been shown to be effective in vertical nystagmus.
But there's no reason not to try it.
But there's no reason not to try it. But there has been, yes. So we've not got any trials. So what I've tried to do is cover as much evidence as I could to show you that there are different options out there. Yeah.
I've been on memantine for 3 years. Is there anything known about the long-term side effects for it?
So actually memantine's used for Alzheimer's disease. That's what it's licensed for. So in terms of the brain, we would expect it to have a protective action. But I don't, again, memantine's it's a newer drug than sort of gabapentin. But I don't know of any problems being on it long term. Yeah.
Just out of curiosity, has there been any work on using the cannabinoid pathway to regulate, possibly downregulate?
Anecdotal.
Yeah.
Yeah.
Forgetting about the anecdotal.
I worked on using glaucoma out the bits that are useful for glaucoma years ago, but they found you have to keep putting the drop in, which kind of makes sense, right?
Yeah.
But you have to put the drop in every few hours, so it kind of fizzled out from glaucoma point of view.
Oh,
So I don't know if that tells us anything, but as far as I'm aware.
Thank you.
Let us know.
Do you guys know of any any holistic trials or treatments that are underway?
No, I mean,
I'm not, what exactly were you thinking of?
I don't know, like maybe aromatherapy, yoga, breathing techniques.
Oh,
I'm not really
yeah,
sure.
actually,
I'm trying to figure out if there's anything.
were you in Rich's session this morning?
No, I wasn't.
Oh, he talked about having patients do a 12-week course of mindfulness meditation. And that a number of people are able, at least transiently, to reduce their nystagmus. I saw someone in my lab several times who he describes it as a breathing meditation, and I've got recordings of his nystagmus going way down. And he's able to continue to look at things while he's doing this, so he's not just sort of zoned out.
Would that be stress reduction, perhaps?
Possibly,
knows?
yeah.
I hate to keep saying we don't know, but it's mainly because we don't. But there's a lot of evidence that meditation does have sort of central effects on the brain. So whether it's just stress reduction or turning down some other level of activity that helps regulate the nystagmus, we really don't know. Rich says he hopes to publish those data, and it's something that I think we need to look at more.
But it is notable that there's lots and lots of very different ways of essentially doing that,
Yeah.
reducing in a
Yes.
sort of kind of nervous activity, if you like, and they're all working in totally different ways.
Yeah.
And I think people think they generally have some reasonable effect, but they're all doing it in very different ways. So it makes you wonder how.
I think one thing I would say is from our trials is that we know that when we, for the big trial, how many measurements was 17, was it?
So how many? So 16 examinations.
16. So we know that nystagmus is variable. Even when we measure it properly and try and control everything, every measurement is different, and you have to account for that. And so I think one of the problems with alternative medicines is it's very difficult to test it objectively. Like with a drug trial, you can create a pill, a placebo that doesn't have the medication in it, so you can compare it to that. But it's quite difficult to compare some of these therapies and know whether the effects are genuine or just a
placebo
effect.
effect.
And so what I would say is, I mean, it's good to try things. There's nothing wrong with that, but you've always got to think about what it's costing you, I would say. I think there's a potential for being exploited is one of the things that we would raise, just because it's difficult to test some things.
I was just going to say, I know here, it sounded like Rich was talking about a commercial course. I know at my university, I think it's actually the Buddhism Society, I think offers free classes in mindfulness meditation. And at least that's an instance where the intervention is a pretty low side effect profile. So, but no, as Frank's saying, no one's really done a proper trial where you might do something like sit and listen to restful music for the same amount of time without actually actively engaging in meditation, because we really, and especially if the placebo effect in nystagmus is actually doing the same thing as stress reduction, the definition of placebo gets a little fuzzy. Yeah, because it may actually be a form of intervention. So it makes sense. And then,
Placebo is a positive.
Well, in a way, there's evidence it is. It's not. So it's a real hard thing to answer.
Okay, I think we're out of time limit here. The experts will still be around if you haven't gotten your question answered. But before we quit, on behalf of ANN, I would like to present Rebecca with a small gift and thank her for giving us a presentation.